that tip.
Yeah, I mean, I agree. Just to confirm, it's whenever something is a little bit unusual, it's kind of you owe it to yourself to explore a little bit more. I think that's my advice. If something like if an unusual diagnosis comes to you as like or you have this type of rare tumor, maybe it's the best thing to seek another opinion. You may still be very comfortable with your initial physician, and it's great. But they may be giving you the exact recommendation that a tertiary care center would give. But at least if you kind of saw that second opinion, that consultation, you'll feel more comfortable, and you feel okay. Now I'm in the right place, and I prefer to be in that place where you're comfortable with. But at least you get that confirmation because rare things, common things are easier to deal with. A lot of people tend to see them and tend to be able to deal with them. When it comes to something unusual or rare, it's better to get that advice and that confirmation that you're on the right track.
Those are excellent tips. Thank you. Okay, moving on with the questions. We have many more adding on to the list here. There's one, Dr. Lee, around micropapillary features. Often are called for early radical cystectomy, and our listener wants to know if there are any bladder sparing options.
Yeah, so traditionally the study out of MD Anderson that originally described their experience with micropapillary tumors had described that with early radical cystectomy, the survival rates were better than those patients who were initially treated with BCG. And even those patients who were initially treated with BCG and then had delayed radical cystectomy. So, again, pointing to the importance of early surgical consolidation for these patients. But, as our experience collectively has grown, and, perhaps because of more recognition for these types of tumor, I think on the one hand, we're picking up, micropapillary tumors that are existing at 1 to 5%, say, of the entire tumor. So whereas before that, those micropapillary tumor may have just been treated as conventional urothelial cancer, we're now picking this up because of the widespread knowledge of this entity. And I think on the other hand, we're also becoming more comfortable at treating these patients as long as they just have focal micropapillary tumor. Had plenty of patients who have focal that were treated with BCG who had a good response.
Thank you, Dr. Lee. Dr. Al-Ahmadie, I'm gonna throw two questions your way just because we're running short of time and I want to consolidate. So one is a question around tumor type. Does it change from TURBT to cystectomy? That's question number one. And the two is not quite related, but it deals with AI in pathology and your thoughts on that and whether it helps avoid misinterpretation.
Yeah, absolutely. I mean, there are a lot of studies addressing the first question, the TUR versus cystectomy. There's high concordance between what you see in the TUR and what you see in the cystectomy. That's the one part. The second part is because when you do the TUR, you already took part of the tumor out. And in the cases where there is still tumor left in the cystectomy, there is a chance that there's another component in the cystectomy, the tumor that's in the cystectomy that was not represented in the TUR that might be there. So there's a small chance that there's going to be some discrepancy. But at the same time, there's a high level of concordance and you have to make the diagnosis based on a TUR. So even if there is a little bit of discrepancy, that's kind of acceptable. And it's just the fact that, inherent to the process that the diagnostic process. If you take everything out by the TUR, then obviously there's not going to be any discrepancy. But there's a small chance that there is something that may not be represented or sampled by the TUR. Yes. It could be unlikely that it may be the relevant part, but other than that, the TUR is pretty adequate for the most part. Now, talking about AI, I think if there is one bot that could help, I think it's in this variant histology and these subtypes, but we're still very early on because it's a pattern recognition, it's an image analysis. As long as you train the AI well, if you wanna keep these histologic subtypes the way they are now, you have to train the AI very well, recognizing the standard classic examples, and the AI can more easily produce the same diagnosis and reproduce the same diagnosis. Because they're not going to be a lot of or any variability from morning, evening, any time of the day, any time of the year across pathologists. If you want to dismiss all these histology subtypes and let AI come up with its own classification, that can help, it can happen, but then they need to have a lot of samples for AI to be able to establish and account for all the nuances and the variations that exist across all tumors of the bladder. But definitely it's an active area that a lot of people are interested in, and we look at it as something that can help us in the future to standardize the recognition of these histologic subtypes.
Oh, that's good to hear. All right, thank you. So Dr. Lee, this question is for you. For high-grade T1 non-muscle invasive bladder cancer with less than 1% micropapillary features, what kind of HER2 targeted agents are showing promise?
Yeah. So that's a great question. We actually don't have any HER2 targeting agents treating non-muscle invasive disease. Because as non-muscle invasive disease overall has relatively good prognosis. And it's considered that like these systemic agents that we have, whether it be targeting HER2 or not, may actually incur too much toxicity to be tolerated for patients with relatively well-treated disease with the standard of care such as BCG. Now, with that being said, there are studies that point to the presence of HER2 mutations within NMIBC that will actually confer a higher risk for progression. So, that's an active area of investigation as we speak. But also there are companies that are making these antibody drug conjugates and formulating it for administration within the bladder, just like BCG, just like intravesical gemcitabine docetaxel, so that we can, help avoid all of the toxicities that come with the systemic agent, but hopefully still get the benefit of the treatment.
Thank you. And there's a lot of questions here regarding the different subtypes, asking about recurrence. Are any one particular subtype, more likely to occur than other? Any general comments that you can make? I know that can be very specific.
Yeah. I'll just start by saying there are certain tumors like squamous, like sarcomatoid, that tend to locally invade. So as long as your surgery was done well with negative margins, and you're now a few years out from surgery, chances are you're cured. And then there are those diseases that tend to metastasize to distant parts, such as plasmacytoid, a small cell carcinoma. And so for those, I would say that even with a well-done surgery, patients tend to be still at risk for developing metastasis, sometimes even years out. That one patient that I was talking about with plasmacytoid, he lived about 5 or 6 years out from his original surgery. And mind you, this was a major pelvic exenteration where we took out both of his bladder and his rectum. And he originally had a end colostomy that was made from his transverse colon because everything was just so glued in. And nevertheless, we're able to kind of, take down his end colostomy and make use of his descending colon and buy him a few years. But even after 5 or 6 years, that patient unfortunately still developed metastasis and eventually passed away from plasmacytoid bladder cancer.
Thank you. And this is a really interesting question. I don't know either of you would like to answer. So one of our listeners wants to know if conventional urothelial carcinoma can it metastasize as a rare histological subtype?
Maybe I can take a shot at this. It's very, very rare. Usually, we've looked at so many cases. It's like in a single hand scenarios when you have a histologic subtype manifesting in the metastasis that was not present in the primary. In general, you'll find it in the primary, the TUR or the cystectomy, and you'll find it in the metastasis. Sometimes it could be very little in the system, in the TUR, like a micropapillary, for example, is a bad actor. You can have 5% in the primary, but then all the lymph node metastases are micropapillary, like 100%. But it's very unusual, for example, to see micropapillary when the primary tumor did not have it, or like a glandular when the primary tumor did not have it. Does it happen? It does, unfortunately, but it's extremely, extremely rare. But we go to extra length to make sure that it's not another tumor type before accepting that this is still a bladder tumor that just was not present in the primary. Because sometimes you can have two tumors manifesting within the same patient. So it's unfortunate, but it can happen. But again, these are all rare scenarios.
Thank you. And the last questions, because we're at time. There is a question about upper tract urothelial tumors, whether they have a different histology than the bladder tumors.
Yeah, maybe I can also put. Now they're lined by the similar urothelial lining. They're a little bit different, embryologically how they develop, but the lining is very similar, and the tumors are pretty much the same. Any histologic subtypes that one sees in the bladder can happen in the upper tract. The prevalence may be different. Maybe they're less common in the upper tract because we see a lot of non-invasive, they're low-grade tumors in the upper tract. But any histologic subtypes in the bladder can happen in the upper tract.
Right. Thank you. I have one last question for the both of you, as it is our tradition here to ask our guest presenters. What is and you have so many you share so much information with us today. And aside from the really important one about really going to a center that has this expertise and knows how to treat this type of subtypes of bladder cancer, what is a takeaway that you would like our listeners to leave with today? And we'll start with Dr. Lee and then Dr. Al-Ahmadie.
Yeah, so I would say that, it's very rare, very scary to get these rare diagnoses of bladder cancer. But, it's very difficult to study these tumors. But, with that being said, I do think that cumulatively we have a lot of evidence already for a lot of these tumors, albeit based on relatively small numbers compared to conventional urothelial carcinoma. But we have, in general, a pretty good idea of how to treat most of these diseases. Now, with that being said, this is where medical innovation continues, is to understand from the biological perspective how these tumors come about and whether there are any Achilles heels that we can find so that we can develop more effective treatments. So, like Dr. Al-Ahmadie was saying, with cutting edge technologies that's advancing on a daily basis, hopefully we'll be able to come up with new insights and we'll be able to come up with better treatments.
Yeah, I couldn't agree more. I think it's a great message. What I would also add to that is, again, whenever anyone encounters these unusual diagnoses, I think it's important to seek out what is available. I think trying to reach places or entities with resources like advocacy, groups like Beacon, publicly available resources, national cancer guidelines, entities like this, they provide a lot of information that can help. May not necessarily have the specific answer, but at least they can give you clues and ideas where to seek the right answer. So I think that would be my advice, is not to settle for whatever you've been told and just go with it. I think it's important to always seek more answers to a lot of questions. A lot of people will have a lot of questions, and it's important not to settle and accepting anything that is not convincing if it is not convincing. So there's always help, there's always resources if you try to reach out.
Thank you both for for spending this hour with us and for those wise recommendations. We really appreciate all the work that you're doing in this space, and thank you for supporting our community.